Thank you for coming. I'm sorry we're on a little bit late. We had some audio and visual video problems in setting up the webinar, but it's all set to go now. This afternoon we're going to talk about low back pain, diagnosis and treatment. And I'm Dr. Filner, and I practice in Rockville, Maryland. We want you to give us some feedback during the presentation. If you want to ask any specific questions, just put them in the chat room box on the right of your screen. And if it's a general question that will help everybody, I will try to answer it right away. Otherwise, if it's a personal question, you can either ask it at the end or through the email address that we'll give you at the end of the talk. We certainly want you to help us continue to make this a very positive experience for all of the listeners who join in. Briefly, just to let you know where I'm coming from, I'm a board-certified anesthesiologist and practiced that for 19 years. Unfortunately, I developed Meniere's disease and had to stop working in the operating rooms. Luckily, I met Dr. Travell when a few years actually before this happened, and she helped me get started in a pain practice. And I worked with her for approximately 10 years, and she clearly opened my eyes to a whole new world of possibilities for treatment of chronic pain problems. During the first 15 years of this pain practice, and I've been doing this now, as I said, for at least almost 24 years now, I did more than 250,000 trigger point injections. That's all we had at that time. In 2004, I began using the ML830 laser, and it has totally changed my practice. I have now done more than about 120,000 trigger points, individual trigger points that I've been activated with the low power laser. One of the things that's really important for anyone who treats chronic pain is to think outside the box. Many of the things we learned 30 or 40 years ago in our classrooms and in our initial clinical experience turned out to be wrong or partially wrong, and I think we need to think outside that box and not place patients in a pigeonhole as soon as we hear the magic words that then determine how we will continue with our diagnostic evaluation as well as our treatment. This is the most important slide here today. Back pain is clearly one of the most widespread conditions in the United States today. It's probably one of the most common problems that people seek medical help for. Some people have estimated that nearly 50% of the population will suffer from some type of back pain at some time in their lives and will need appropriate treatment. So it's clearly a very important and obviously a very expensive in terms of the cost of the healthcare system condition, and it behooves us to really be very good at the diagnosis and treatment and try to keep the cost of that down. And I'm sure most of you will realize that one of the ways to keep that cost down is to minimize surgical procedures. In any event, what's really important is that your clinical examination must include a good neurologic exam as well as an educated muscle exam, both looking at the patient, checking their range of motion, and extensive palpation for trigger points at the site of their pain complaint, or if you've interpreted their pain complaint as the reference zone, you may need to look elsewhere for the trigger point. When you deal with a patient as the initial consulting person, you should at least make sure that there's no fracture or tumor and most of the time that requires at least a plain X-ray. And about the only things you can really diagnose that are clinically important are a fracture or a tumor. Simply looking at a plain X-ray and saying there's some narrowing of the disc spaces, that's consistent with anybody who's past 30 or 40, and doesn't give you any real hint as to what the true diagnosis is. MRI scans, most of the people who see, and these are especially surgeons, who see back pain patients primarily as the first contact in the healthcare system, order MRI scans willy-nilly if there's the slightest indication that the patient may have more than just a muscle strain in their view. In my case, I will order if I happen to be the first person to see a patient, I will only order an MRI initially if the neurological examination is positive. And that means there's either weakness or clear dermatomally related sensory deficits. Later on, after about 2 or 3 months, if our initial therapy is unsuccessful, or if new symptoms occur in terms of numbness or tingling or weakness, then an MRI is appropriate. That neurologic exam that I mentioned must include a straight leg raising test. And I'm told by some of the country's most important orthopedic surgeons in academia that the only time a straight leg raising test is positive is if the pain or tingling or tightness goes below the knee. Anything that just goes into the thigh or the buttocks or stays in the low back is not positive. And virtually, according to Dr. Wiesel, rules out a disc problem. If there is weakness in the single dermatome consistent with the patient's pain complaint, or significantly decreased sensation to pinprick in that dermatome is found, that is reasonable inference that there's a radiculopathy. Then an MRI scan is appropriate and most likely will be positive. And one should remember that MRI scans that show simply disc bulges or disc protrusions are not positive MRI scans. Dr. Wiesel, when he was chairman of orthopedics at Georgetown University, did studies on patients who indicated, these actually were volunteers or medical students who were conscripts, who insisted that they had never had back pain. And he also did a study with neck pain, and he got people who insisted they'd never had neck pain. And these patients or volunteers were then tested with an MRI scan, and 70% of them had either bulging or protruding discs. So, and they had never had any symptoms. So most of the time you can disregard bulging discs or protruding discs as causes of a patient's problem. If a patient fits the criteria for an epidural block, you might send the patient for that. And the criteria are not simply, well, a patient has a radiculopathy, let's see if an epidural block will work. What you really need to do is to take a patient who's had their very first episode of back pain, has never had surgery, and has never had any procedure where there might have been some bleeding or scar tissue in the epidural space, because even though one places the epidural block these days very precisely with the X-ray fluoroscope, it still doesn't spread normally if this is not a virgin back, and you may not get a normal response. So epidural blocks are very useful if the patient fits the criteria. and physical therapy aimed at allowing the patient to get through the episode of radiculopathy. Diagnosing radiculopathy, even with a ruptured disc, may not need surgery. It's not infrequent for a patient who has a clearly ruptured disc to have that disc simply dry out, and perhaps an autofusion occurs at that site, or occasionally the patient is basically returned to normal with simply a narrowed intervertebral space. The indication for surgery, these are not one by one, but they need to be all together. A positive neurologic exam, and this is really the most important here, the second one: can the neurologic abnormality be reversed or prevented from becoming worse? If that's a good possibility, then surgery may be indicated. A number of studies have shown that 60 to 70% of patients undergoing back surgery will be no better or will be worse. And these people you hear who are worse are usually worse because scar tissue has now involved the nerve roots, and they have constant burning pain from that. And any attempt to redo the surgery just results in more scar tissue. So these patients are very difficult to deal with. And one should always remember that surgery should not be done purely for pain relief. We can always find some medication or some process to relieve the pain, but should be done as a last resort because you can't undo the surgical procedure once it's done. Far more patients with back pain have myofascial pain than have disc disease. And you'll find that a vast majority of the patients who have back pain, in fact, have several active trigger points that are causing the problem. And you can inactivate these with the ML830 laser with no pain and no risk, and the patient will be able to get these muscles stretched. And if they haven't had this for weeks or months, can be treated very quickly. If your palpation during your careful examination has demonstrated trigger points, you should always look for the iliocostalis and the quadratus lumborum muscles. This iliocostalis muscle, in my experience over these last 24 years, will always be present with chronic low back pain. It's the one that's always there, even if you can't feel it initially. If there are others that are very active, sometimes this is sort of hidden, but it's always there. I have not yet seen a patient over these years with back pain chronically who doesn't have this. Using your laser, inactivate these two muscles that I mentioned, the iliocostalis and the quadratus lumborum, first. Some or all of the trigger points in the buttock and leg will disappear without any specific treatment. And I'll go over this again when we get to the case presentation. That can in fact happen. Doesn't happen all the time, but it can happen. You then need to go on to treat any buttock or leg trigger points that remain. Many of the trigger points, if they don't disappear, will at least be less tender once you've inactivated these two trigger points. And they are more easily inactivated with a laser, and the patient will say they already feel better once you've done those two. One thing you should always remember is when you're dealing with low back pain is to look at the latissimus dorsi muscle. And I'll show a picture of this where it attaches to all of the thoracic and the lumbar vertebrae, as well as the top of the rim of the pelvis, so that if that muscle is tight, it can clearly maintain the trigger points in the low back. So one of the things you have to do as part of the full treatment is to look to make sure